Entering deep water is an immediate entry into a hostile, isolating environment. Every meter of descent increases the physical pressure on the human body, turning what looks like a recreational sport into a severe, multimodal cardiovascular stress test. A diagnosis of cardiomyopathy would seem incompatible with these extremes. Yet having heart muscle disease does not automatically issue a lifetime ban on scuba diving. The hyperbaric environment operates on one unforgiving rule. Any sudden loss of consciousness or cardiac incapacitation underwater is almost universally fatal, unless immediate, highly coordinated assistance is available. A safe dive with a cardiac condition requires an exact calculation of risk. Survival depends entirely on understanding a diver's specific physiological margins before they ever put on a regulator. To determine exactly who is fit to dive, we have to map the precise hemodynamic loads of aquatic immersion directly against specific structural defects of the heart. The sheer physics of entering the water forces immediate, aggressive shifts in human circulation. Looking at this cardiovascular cross-section, we can see the mechanism of the preload shift. Hydrostatic pressure from the surrounding water crushes inward on the limbs. This forces 500 to 800 milliliters of blood out of the peripheral vessels and pushes it directly into the central thoracic cavity. The immediate clinical consequence is a drastic spike in central venous pressure. The heart is suddenly hit with nearly a liter of extra fluid, causing intense right atrial stretch as it attempts to accommodate the rapid volume load. At the exact same time, the body is exposed to cold water, which triggers severe peripheral vasoconstriction. This clamps down the outer blood vessels, sharply driving up systemic vascular resistance and blood pressure, creating a massive afterload spike that the heart now has to pump against. Add in the physical exertion of swimming through dense water, combined with the mechanical breathing resistance of pulling high-density gas through a regulator, and the workload on the heart multiplies even further. A healthy heart compensates for this preload volume and afterload spike by simply beating harder. But for a heart structurally compromised by cardiomyopathy, these physical forces immediately strip away whatever compensatory margins the patient has left. Beyond the fluid dynamics, the underwater environment attacks the electrical stability of the heart. The psychological anxiety of the dive, paired with the physical shock of cold water, causes adrenaline and sympathetic nervous system tone to spike. This surge in sympathetic tone actively lowers the heart's threshold for dangerous abnormal rhythms. Hypertrophic cardiomyopathy is the highest risk phenotype. Notice the thickened ventricular septum and narrow outflow tract. Pumping harder underwater causes this swollen tissue to obstruct blood exiting the ventricle. This thick muscle also makes HCM patients highly susceptible to fatal exercise-induced ventricular arrhythmias. A similar electrical threat exists for arrhythmogenic right ventricular cardiomyopathy, or ARVC. Here, healthy heart muscle is replaced by fat and scar tissue, resulting in severe electrical fragility. The continuous heavy physical exertion required in diving drastically increases the likelihood of those fragile electrical pathways misfiring into life-threatening ventricular arrhythmias. In patients with HCM and ARVC, the hyperbaric environment provides the specific physical and electrical triggers required to initiate sudden cardiac death. Shifting to physical pumping deficits, dilated cardiomyopathy features a grossly enlarged, thin-walled left ventricle with a low ejection fraction. When the 800 milliliter dive preload dumps into this weak chamber, it cannot process the surge. Pressure backs up into pulmonary circulation, directly causing acute pulmonary edema. A similar volume failure occurs in restrictive cardiomyopathy, though the mechanism is different. Here, the issue isn't a weak wall, but a stiffened, non-compliant one. These rigid ventricles cannot stretch to accommodate the elevated filling pressures caused by water immersion, resulting in an immediate failure of the heart to accept blood at depth. In both DCM and restrictive phenotypes, combining a compromised pump with immersion hemodynamics essentially causes the heart to drown the lungs from the inside out. Beyond the structural diseases, the specific medical interventions used to keep patients alive introduce their own severe risks underwater. As this X-ray visualizes, The presence of an implantable cardioverter defibrillator, or ICD, is an absolute, non-negotiable contraindication for scuba diving. The clinical logic is straightforward. If a patient's condition warrants the surgical implantation of a defibrillator, it proves their baseline risk of a fatal arrhythmia is already too high to dive, regardless of whether the device is currently functioning perfectly. Chemical modifiers are equally problematic. The daily maintenance medications used to stabilize cardiomyopathy alter dive physiology in highly dangerous ways. Beta blockers artificially cap the patient's maximum heart rate. This destroys the exercise tolerance they would desperately need to fight a strong ocean current or execute an emergency ascent. Diuretics induce constant systemic dehydration. A dehydrated body fails to off-gas nitrogen efficiently, massively increasing the risk of decompression sickness, commonly known as the bends. Anticoagulants prevent clotting. Under pressure, a minor ear squeeze or sinus barotrauma that would normally cause a tiny nosebleed can quickly escalate into an uncontrolled internal bleed. Ultimately, the hardware and pharmacology required to manage heart disease create absolute hard stops to diving that are just as prohibitive as the structural defects themselves. Before a dive medicine physician will even consider clearing the patient with a history of cardiomyopathy, the applicant must survive a grueling gauntlet of diagnostic data. This flowchart maps the clearance protocol. The physician needs recent echocardiograms, high-resolution cardiac MRI findings, strictly normalized left ventricular ejection fraction measurements, 24-hour Holter monitor data, and a clean maximal exercise stress test. Failure at any one of these nodes routes the patient straight to a red contraindication. The only people who reach the conditional clearance terminus are those with very mild, stable, or fully recovered disease. They must demonstrate strictly normal ventricular function, excellent exercise tolerance, and zero active symptoms. A primary example of this is Takotsubo, or stress-induced cardiomyopathy. If a patient achieves 100% functional recovery with no lingering arrhythmias, they may eventually be permitted to return to the water. This clearance is exceptionally rare. It requires a unanimous, case-by-case sign-off from both the patient's treating cardiologist and a specialized dive medicine physician. Even when medical clearance is granted, the physical dive profile must be heavily restricted to maintain safety margins. Cleared divers must strictly adhere to conservative no-decompression limits. They must restrict themselves to warm water to prevent cold-induced afterload spikes, and they must maintain low physical exertion at all times. Environmentally, they can only dive with highly experienced buddies. Overhead environments, like cave systems or shipwreck penetrations, where a direct ascent to the surface is physically blocked, are strictly forbidden. Hiding symptoms or minimizing a medical history to obtain clearance endangers both the diver and their rescue buddy, who would be forced to manage a cardiac catastrophe in an unforgiving environment. The underwater environment cannot be negotiated with, and it is entirely unforgiving of cardiac failure. Precision clinical diagnostics and absolute patient honesty are the only true barriers standing between a safe dive and a fatal event.